One. And today, what we're going to do is to give you a potpourri of presentations focusing on people who had presented at the last ASH meeting from the Institute. We have 4 speakers. As in the ASH meeting, we give them 10 minutes. We don't allow questions. We will not allow questions right after their talk, and we'll save them for right at the end. So I'm going to decide which order we go. Is that okay? So having made that decision, Julie, you go first.
Thank you.
10
I
minutes.
I thought you said 12 in the email.
We did
So
say 12.
it's
Okay,
more like
then. All
12
right,
and a
then.
half. But I'm going to be very efficient with my time and start sharing my slides. One sec. Sorry. You don't need to see my post-it note. Now, do you see the right slide?
Yes, absolutely.
So thank you for the opportunity to present this today. This was a poster at ASH, so I put these slides together to share with you today. This is the title of this study was called Clinical Trial Availability and Receipt of Guideline Concordant Care among Adolescents and Young Adults with ALL. So AYAs are considered those just diagnosed with cancer between the ages of 15 and 39. And while they share diagnoses with older and younger patients, historically they did not see the same improvement in survival over time. They're the red line below the other age groups. Although with the recognition of this in the early 2000s, there was attention paid to this and there's been significant progress made, there's still a number of diagnoses and patient groups that still face disparities in outcomes. So they have unique developmental needs and a unique interface with the healthcare system in terms of whether they're treated in an adult or pediatric environment. And with all that in mind, the AYAs, the NCI deemed AYAs to be a vulnerable population. So with that in mind, we undertook some initial work to look at LA County Cancer Registry data over a decade, first looking at malignancies common to children and AYAs, and found that in AYAs, there was superior survival in patients that were treated at an NCI designated comprehensive cancer center or children's oncology group site at 21 and under, or at any age at an NCI institution as compared to the non-NCI centers. And in multivariable analysis, we also found this is specific to ALL. We also found in comparison to 10 to 14-year-old patients that were treated at a cancer center, those that were 15 to 21 at the non-cancer center had a 90% increased risk of mortality, but those treated at the specialized site had no difference in survival. So, and again, the 22 to 29-year-olds, there's a 2.6-fold increased risk of mortality compared to the 10 to 14-year-olds at a cancer center, with no change in the cancer center patients. The 30 to 39-year-olds had poor survival regardless of where they were treated. So essentially, care at these specialized centers mitigated the poor survival among AYAs with ALL. And this was theorized to be driven partly by a clinical trials oriented culture, but this phenomenon hadn't really been examined. So and my animation is really off on this, and I'm hoping it doesn't get worse. Why are these specialized centers different? So this was hypothesis generating research, but we dove into ALL in specific. And so in a single cancer center retrospective cohort, looking at the risk of relapse for initially on therapy and then off therapy and adjusting for a number of variables in a multivariable model, we found that AYAs with ALL that were not enrolled on a clinical trial had a 2.6 times the increased risk of relapse. So with that in mind, at the time, so starting in 2012, the NCCN had guidelines for ALL that had different recommendations for patients 15 to 39 than those 40 and over. And I think this is the wrong version is what's happening. Darn it. So I fixed all of this. And this is not gonna, there's no time to go back and get the other one open. It'll be fine. in specific, a clinical trial or pediatric-inspired multi-agent chemotherapy for these patients with pH negative ALL, and a clinical trial or TKI along with their chemotherapy. So with that in mind, we undertook this study with the COG leading. So documentation and delivery of guideline consistent treatment in AYAs with ALL, with the goal of assessing guideline concordance of treatment in the context of current models of care at NCOR sites. So that's the NCI Clinical Oncology Research Program, with the goal of leading to intervention studies and optimizing the equity of care delivered to AYs with ALL. So this is an intergroup study where we as COG were the lead, but we had adult group study champions from the Alliance, ECOG, Akron, and SWOG. Patients were eligible to be included in this retrospective cohort if they were 15 to 39 at diagnosis and treated at a participating NCOR. AIM-1 used patient-level retrospective medical record data that was contributed by the NCOR sites themselves to evaluate the proportion of AYAs with ALL that received guideline concordant care. And AIM-2 used facility-level cross-sectional data based on a pre-questionnaire and then a site questionnaire to determine the impact of facility and physician characteristics on the likelihood of that guideline concordant care. So looking at the participating institutions, the study was activated by 33 NCORs representing 481 affiliates and sub-affiliates. In terms of institutions that truly participated, there were 87 CTEP IDs and 31 NCORs participating. Each of these facilities completed a pre-questionnaire that identified which components of their NCOR were actually an independently operating clinical facility, and this was a study-specific definition that was an independently operating location of care. And so there were 84 clinical facilities that then, based on these pre-questionnaires, then completed a site questionnaire that provided facility level characteristics specific to their CF. So very briefly, the characteristics of those healthcare settings, in terms of the number of AYAs with ALL treated on average per year, the vast majority of, regardless of whether they were in a pediatric model, an adult internal medicine model, or mixed, where pediatrics is embedded within a general hospital, most did not see a high number of ALL patients each year that were in the AYA age group. So this under 5 is the green, but if you go under 25, then that's the blue and the green together, which is a very large percentage of the patients, of the sites, and very few of them were seeing over 25. So in terms of facility level characteristics, again, I fixed all of this. We captured structure and process related characteristics, as well as psychosocial services that were both general and then AYA specific. And because I fixed all of this and it's not fixed, I'm going to just put it all in here now. But we found that there were a larger number of pediatric and a lower number of adult facilities were affiliated with a counterpart. And then more academic in pediatrics than the adult or mixed. The message here is most of these sites did not have any AYA specific process related help or services, and that the frequency of them contacting each other was very high in the adult groups. So in terms of the patient selection, we received a patient list from each site, and there were 301 patients on that, 299 of whom were actually diagnosed within the right years. We sampled, COG study staff did a random sampling of 270 patients, proportional to the contribution from each age group. And we had, after central review, we had 229 eligible patients. Among them, 2 did not have a documented treatment plan, so 227 were included in the analyses. In multivariable analyses, we showed that the odds of guideline concordant care were lower and if patients were at an adult or internal medicine model facility, but that the volume of AYAs with ALL seen at that facility was not statistically significant in terms of predicting their receipt of guideline concordant care. So questions remained, and we wanted to augment this with real world data, because when you see that The bars represent the patients that received guideline concordant care, and all of them received a pediatric inspired regimen. However, the percentages reflect the number of patients that were enrolled on a clinical trial, which is far fewer than the total. And that was the same across age groups. So this planned secondary analysis included these AY, changed all. We had basically identified open therapeutic clinical trials at participating NCORE practices using CTSU data and augmenting that with clinicaltrials.gov when necessary. We used logistic regression to model the odds of trial availability and enrollment, adjusting for the facility characteristics and provider specialty, and to look at receipt of guideline concordant care, adjusting for these models as well. The patients had trial available 100% of the time at the pediatric clinical facilities, over 90% of the mixed, and just over half of the adult clinical facilities. And I made figures of all of this too. I'll stop. Because this wasn't making sense. So in terms of the patients that had a trial available, any of them versus none of anyone having a trial available, was still only a third or less. The majority of those being treated by a pediatric oncologist, though, when they did have a trial available, most were a cooperative group trial. And 92% of those with a trial available had guideline concordant care, as opposed to 68% who had none. I had fixed all of this. So this is that in pictorial form. So in terms of modeling trial availability, the odds of of it being available were higher at a pediatric or mixed facility than at an adult facility, but the volume was not significant. Trial enrollment among those with a trial available, 48% enrolled. And among those with a trial available, there was a higher odds of enrolling if they were treated in pediatric oncology. But again, the volume was not associated with trial enrollment. This is the proportion of patients who had a trial available were treated with guideline concordant care the majority of the time, with a smaller proportion when one was not available. So AYAs had a higher odds of receiving guideline concordant care if they were treated at a clinical facility where a trial was available, whether they were eligible or not, and if they were in pediatric oncology, whereas volume was not associated with guideline concordant care. So the limitations are such that these data are supplied by retrospective medical record abstraction, so limited to documentation. And the available trials in COG and CTSU had very granular detail available about the dates of the trials being opened at each facility. And we compared that to when the patient was diagnosed. So it really did coincide with the trial being open at the facility they were treated at and when the patient was diagnosed. And that was based on CTEP ID, consistent with our 16N1 data. But there were a subset of trials not available on CTSU. And so we had to use clinicaltrials.gov, which was less perfect. And some groups obviously were limited by small numbers that did not receive guideline concordant care, which made some of those confidence intervals wider. But so in summary, AYAs with ALL treated at NCORE practices have a higher odds of receiving guideline concordant care if clinical trials are available, regardless of whether they're eligible for that trial, and having a trial available if they're treated at a pediatric or mixed institution as compared to an adult practice, as well as enrolling on a trial of treated by pediatric versus adult oncology, such that strategies to improve guideline concordant care for AYAs with ALL should include optimizing clinical trial availability and, by extension, disease expertise across facility models. And we have a qualitative aim that is completing with manuscripts in progress. These are the funding, these are all of the grants that supported this work and all of the team that worked on this together.
Thank you. Thanks, Julie. Radhika, you want to go next?
Yes, we should start sharing. Is it in the correct mode?
Yeah, absolutely. Perfect.
Okay. So the title of my presentation is Clonal Hematopoiesis and Risk of Mortality After Incident Ischemic Stroke. So I believe most of the audience is from ICOS, and I have talked about clonal hematopoiesis in the past, so I'll be brief. So clonal hematopoiesis is referred to as acquisition of somatic mutations in blood stem cells. And as we age, we acquire a lot of somatic mutations. It's part of normal aging. And while most of these mutations do not cause any problems and just stay in our blood cells and other cells, some of these mutations can impart a survival advantage to the cells that are harboring these mutations. So over time, they propagate and give a survival advantage for the cells that are harboring these mutations, leading to the development of a clone. And as we get more older and older, we develop more and more mutations that lead to development of malignancy. While the association between clonal hematopoiesis and hematologic malignancies has been known for a long time, I guess like in the last 10 years, there have been a lot of studies that showed that individuals who have CHIP also have at least a twofold increased risk of cardiovascular disease. So increased risk of heart attacks, strokes, and mortality from cardiovascular disease. And this is thought to be related to secretion of inflammatory cytokines, so lots of interleukins that are secreted by these clonal cells that result in vascular smooth muscle proliferation and also increased atherosclerosis. A recent study, which included 581 patients with incident ischemic stroke. So these patients were all diagnosed with new stroke, and they collected blood samples at the time of stroke development. And the study showed that in individuals with stroke who have clonal hematopoiesis at the time of stroke, there was increased risk of recurrent strokes, heart attacks, as well as mortality compared to individuals who don't have clonal hematopoiesis. They also showed that people who have clonal hematopoiesis have increased large vessel atherosclerosis, white matter lesions on MRIs, as well as increased inflammatory markers like CRP and interleukin-6. And as you can see in the figure, the higher the variant allele frequency, so the variant allele frequency is the percentage of cells that carry these mutations. And traditionally, CHIP is defined using a variant allele frequency of 2%, based on the detection limit of whole exome sequencing, which was initially used to study CHIP. But then studies have been able to detect CHIP at lower frequency. So the targeted sequencing allows us to detect CHIP clones, which are present at really small amounts. So this study used a cutoff of 1% to define CHIP. And as shown in the figure, in individuals who don't have CHIP on the red line here, as the variant allele frequency increases, so light blue line represents variant allele frequency greater than 10%. So the mortality is higher as the variant allele frequency increases. However, this study included only white individuals. It was a European study and had a relatively short follow-up time of 3 years. And the study did not show if there were any differences based on demographic characteristics. So the association between CHIP and mortality in diverse populations with stroke remains unclear. So the study is a simple study. We had only one aim of examining the risk of mortality associated with CHIP in individuals with incident ischemic stroke by age, race, and sex, because studies have already shown that the older we get, there is increased risk of CHIP, as well as some signal towards maybe more increase of CHIP in men as well as white individuals. The study population was derived from REGARD study, which is a large population-based study that recruited individuals from mostly from the southeast of the US and 48 states and more than 2/3 of the counties in the US. So it's a longitudinal study that enrolled approximately 30,000 individuals greater than 45 years of age between 2003 and 2007, primarily to detect if there are any racial and regional disparities in stroke-associated outcomes. And 95% of the study participants had blood sample at study entry. So as you can see, about half of the participants are from Black population. So that was the main goal of the study, to see if there is any increased adverse outcomes in Black populations. So from the REGARD study, by the time of adjudication that happened in September of 2021, there were 1,744 individuals with incident stroke. Of these, 1,566 had incident ischemic stroke, and 1,112 had DNA sample available for sequencing. So we used error-corrected targeted next-generation sequencing, which is a sensitive sequencing that is used to detect 24 genes that harbor these clonal mutations, and they constitute about 95% of the CHIP mutations that have been reported. These are the characteristics of the study participants. So no major differences other than what we expect. So more CHIP in older people, more CHIP in white individuals, and slightly higher CHIP in men. And no major differences in cardiovascular risk factors, as you can see in people with and without CHIP. The median time from stroke to mortality was 4.6 years. So 24% of the participants in the study cohort had CHIP at a variant allele frequency of 2%, and 8.3 had VAF greater than 10%. And as shown in previous studies, most of the people had single CHIP mutations. 16% had one CHIP mutation, whereas 2% had more than 3 CHIP mutations. The common mutations included DNMT3A, TET2, and ASXL1. This is again similar to what has been reported before. And when we look at the CHIP prevalence based on the demographic characteristics, there is more CHIP as people get older. So about 30% of those who are older than 65 years of age, and more CHIP in white individuals, so 27% compared to 20% in Black individuals. No major differences between men and women. So in the overall study cohort, we haven't seen any increased mortality with CHIP. So we have looked at CHIP yes versus no at a variant allele frequency of 2%, and there is no increased risk of mortality with multiple mutations or based on variant allele frequency. And all of these analyses that I'm going to show are multivariable models which are adjusted for age, cardiovascular risk factors like hypertension, diabetes, dyslipidemia, smoking, atrial fibrillation, as well as time from study enrollment to stroke. So compared to the previous study that collected CHIP, CHIP was measured at the time of stroke, whereas in REGARD study, we measured CHIP at baseline and then followed these individuals for development of stroke. And then mortality happened later on after stroke. So we then looked at association of CHIP and mortality in different demographic groups. Again, when we look at CHIP at a variant allele frequency of 2%, so yes versus no, there was no difference in mortality in the different demographic groups, either by age, sex, or race. And when we look at the number of mutations, so the top portion includes people who have one CHIP mutation. There is no major difference based on these associations with different demographic groups. But when we look at individuals who had 2 or more mutations, we see that there is increased risk of mortality when individuals are less than 65 years of age, or in men. Similarly, when we look at variant allele frequency, more mortality risk in individuals who are less than 65 years of age and in men. So in summary, CHIP was prevalent at 24% of participants with incident ischemic stroke and correlated with increasing age. And CHIP was associated with mortality after a median follow-up of 5 years after stroke, only in individuals who are less than 65 years of age and in men with multiple mutations, or if the variant allele frequency was greater than 10%. There are several limitations to the study. As I mentioned before, CHIP was measured at a later time point compared to the baseline. So considering that CHIP is it's a dynamic process, so people can acquire more mutations as the study moves on. We haven't collected blood samples at the time of stroke, so there is that approximately 4 to 5 year lag time between the CHIP was measured and then stroke happened, and then after that mortality happened. And then we also had quite a bit of missing DNA samples. But when we looked at the characteristics of the participants that had DNA sample versus who did not have DNA sample, there were no major differences in terms of cardiovascular risk factors or other factors. So I think that was a minor limitation. And CHIP was measured at 2% variant allele frequency. And we could look if there is any difference based on, like, maybe if there is a microchip. Approximately 50% of the participants had CHIP if we use a 1% cutoff. So we could look at those. And also, we don't know if there is any difference in CHIP based on like different kinds of mutations, which we could explore in future studies. But I think overall, there is some signal showing that maybe CHIP is not a risk factor for all the demographic groups, and maybe there are certain groups that are particularly vulnerable to having adverse outcomes after stroke if they have CHIP. So I think future studies can use this as a way to risk stratify patients and to target interventions on high-risk populations. I think that's all I had.
Wonderful, Radhika. I mean, I even after being part of the study for so long, I still have new questions every time.
Okay, we'll talk about it. Yeah.
We'll discuss that. Nora, you're next. Sorry, Aman, you're last.
Okay. Okay, can you see it?
Yeah.
Smoking interact to increase the risk of lung cancer after BMT. So advances in transplantation and supportive care have improved survival after BMT. However, those survivors carry a significant burden of morbidity, including subsequent neoplasms, which are the leading cause of premature death. And so among the subsequent neoplasms, lung cancer has poor survival, emphasizing the need to identify high-risk groups for targeted screening and early detection. So cancer survivors who received the standard chest radiation are known to have higher chances of developing lung cancer later. This risk. So unlike conventional chest radiation, TBI delivers a smaller dose of radiation but exposes a large volume of the lung. So this raises two important questions. First, does TBI increase the risk of developing lung cancer later on? And the second question, does cigarette smoking make this risk even higher when combined with TBI? And to answer these questions, data were retrieved from the BMT survivor study. It's a multi-institutional retrospective cohort study with prospective follow-up examining the long-term outcome of individuals who underwent BMT between 1974 and 2014 at the UAB City of Hope or University of Minnesota, and survived for 2 or more years after the BMT. And the entire BMTS cohort is linked periodically with the National Death Index and the ACRN database for vital status and cause of death. So participation involved completing a BMT survivor study survey that collected detailed information on patient demographics, medical history, chronic conditions, and subsequent neoplasms, lifestyle factors, and overall health status. Clinical data were retrieved from the participant medical record, and the vital status were retrieved from the NDI or the medical records. Our outcome of interest was the development of lung cancer after BMT. So for the alive participant, information was obtained from the survey, and participants were asked at any time after BMT, were you diagnosed with another cancer? And those who answered yes were then asked to specify the type of cancer, the date of diagnosis, and the institution where it was diagnosed. And for self-reported lung cancer, we confirmed the diagnosis by reviewing the pathological reports or the medical record documentations. For the deceased participant at the time of the study, lung cancer was assessed using the cause of death information from the NDI+, and age at diagnosis was recorded as the age at death. Our main exposure of interest were total body irradiation and cigarette smoking. So we divided TBI into two groups, those who received TBI and those who did not receive TBI. Smoking status was categorized into three groups: non-smoker, former smoker, and current smokers. Of the cohort, 2,346 were deceased at the time of the study and were included using their available NDI cause of death. So we approached 6,644 individuals, and 66% of those completed the BMTSS survey, either directly or via proxy. So in total, 6,881 was like our entire cohort. And from this cohort, 3,767 participants were eligible for our subgroup analysis. So our analysis plan that we examined the risk of subsequent lung cancer in the entire cohort. And to examine the effect of TBI and cigarette smoking, we conducted a subgroup analysis restricting the cohort to BMTS participants who completed the survey, were 18 years or older at time of the survey, so thus they provided smoking history data. They were exposed to TBI with no history of chest radiation. This slide here shows the key characteristic of our cohort. The median age at BMT was 46 years. About 59% of the participants were male. And in terms of race and ethnicity, the majority were non-Hispanic white at 73%. Next is the indication for BMT. So the entire cohort, the most common diagnosis was non-Hodgkin lymphoma at 23%. And for the autologous transplant, plasma cell disorder and non-Hodgkin lymphoma accounted for over than 70% of the cases. And in the allogenic BMT recipients, AML and MDS was the most common. So along the allogenic BMT recipients, 55% developed chronic GVHD. The median follow-up was 12 years from BMT to subsequent lung cancer death or the last contact, which was May 2024. By the end of the follow-up, around 57 had died and 1.6% had developed lung cancer. So this is messed up. Sorry. Okay, this is not the correct slide. Okay, so this figure is supposed to show the cumulative incidence of the lung cancer over the 30 years of follow-up among the entire cohort. And we had a total of 113 individuals were diagnosed with lung cancer at a median of 7 years post-BMT, resulting in a 30-year cumulative incidence of 1.8%. And compared with the general population, BMT recipients were at 1.4-fold increased risk of developing lung cancer. So stratification analysis by TBI exposures showed no statistically significant difference between those who received TBI and those who did not receive TBI with p-value of 0.3. And the multivariable analysis revealed that exposure to TBI was not associated with increased risk of lung cancer, but age at BMTI increased the risk of lung cancer. In this subgroup analysis cohort, nearly half of the cohort were non-smoker, 40% were former smoker, and 5% were current smoker. A total of 51% had received TBI. So we observed a statistically significant interaction between smoking and TBI. So as a sequence, we created a composite variable combining smoking status and TBI exposure with no TBI non-smoker as a reference group. So the multivariable subdistribution regression analysis revealed that non-smoker with TBI and non-TBI former smoker did not show a statistically significant increase in lung cancer. Former smoker with TBI and current smoker without TBI had an increased risk of lung cancer. And the highest observed risk was among current smoker with TBI exposure with the hazard ratio of 4.7. So these findings underscore the compound impact of smoking and TBI exposure, specifically among current smoker, on the risk of developing lung cancer. And additional risk factors associated with subsequent lung cancer included age at BMT, male sex, pre-transplant exposure to anthracyclines and/or topoisomerase inhibitors. So in our cohort of BMT survivors, 113 developed secondary lung cancers with a median onset of 7 years post-transplant. Overall, the cohort had 40% increased risk of developing lung cancer compared with the general population. In the subcohort survival with available smoking data, we identified statistically significant interaction between TBI and smoking status, with the highest was observed among in the current smoker who had been exposed to TBI. Intermediate risk was seen in two groups, the current smoker without TBI and former smoker with TBI. And most important, TBI exposure alone in the absence of smoking did not increase the risk of lung cancer. We also found that older age at transplant, male sex, pre-transplant exposure to anthracyclines or topo inhibitors were additional independent risk factors for developing lung cancer. As with this study, it is important to acknowledge the limitation that may influence our finding. First, that BMTSS relies on self-reported data for identifying secondary cancers. While most of these reports were verified through pathology records or medical chart reviews, there is still a possibility that some cases were missed, particularly if participants did not report them. So this could lead to an underestimation of the true incidence. For participants who were diseased at the time of the data collection, cancers were identified through death records. So in these cases, the date of diagnosis was assigned as the date of death, which may reflect the actual time of disease onset. We also lack detailed information on the duration of smoking, which limits our ability to assess dose-response relationship. And additionally, due to the small numbers of lung cancer cases, patient exposed to non-myeloablative doses of TBI, we were unable to evaluate the impact of low doses TBI exposure. And finally, some factors that could influence lung cancer risks, such as genetic predisposition and environmental exposure, were not captured at this data set. And so in general, our analysis showed that BMT survivors who received TBI and were current smoker faced a substantially increased risk of developing subsequent lung cancer. In contrast, TBI exposure alone with cigarette smoking was not associated with an elevated risk. And this is critical because it suggests that the risk is not solely driven by the treatment exposure, but also by the interaction between TBI and smoking behavior. And these findings strongly support the need for personalized surveillance strategy, especially for the BMT survivors, such as current smoker who received TBI. Tailoring follow-up care based on individual risk profiles could improve early detection and long-term outcomes. And of course, we have to acknowledge our participating institution and funding organization. Thank you.
Thanks, Nora. Aman, are you ready?
Yeah, give me a second. Okay, do you see it in the correct format?
Yep.
Right. All right, good morning, everyone. I will be discussing results from our study examining changes in body composition during early phases of treatment and risk of relapse in childhood Hodgkin lymphoma. So as many on the call likely know, Hodgkin lymphoma has served as a paradigm of success in pediatric oncology, and survival for childhood Hodgkin lymphoma has remained excellent, whether patients are treated with chemotherapy or with chemoimmunotherapy in the more recent years. But despite this excellent overall survival, some patients will experience a relapse after upfront therapy and require further treatment with high-dose chemotherapy and autologous stem cell rescue, as well as radiation therapy, which places them at significant risk of long-term morbidity and early mortality. Improving risk stratification could therefore lead to reduction in relapse rates and even provide an opportunity for treatment de-escalation. Our current risk stratification for childhood Hodgkin lymphoma relies on disease stage and presentation, presence or absence of bulky disease, and B symptoms such as fever, night sweats, and weight loss. It is well known that among adults with cancer, poor body composition assessed as low skeletal muscle and excess adipose tissue mass is associated with several inferior outcomes across multiple cancer types. These outcomes include worse survival, excess toxicities from chemotherapy, contributing to lower adherence to prescribed chemotherapy, and an overall lower global health-related quality of life. However, the role of body composition in childhood cancer is unclear. As clinicians, we are all familiar with using a patient's height and weight and calculating body mass index or BMI to assess adiposity, but data clearly show that BMI is a poor measure of muscle and adipose tissue mass. In contrast, body composition assessment allows for precise measurement of skeletal muscle and adipose tissue. It can be easily measured using computed tomography scans or CT scans routinely performed for cancer staging. And work from our group has shown that low skeletal muscle density is associated with early toxicities in children with lymphoma and rhabdomyosarcoma. We have previously demonstrated that extremes of adipose tissue mass at diagnosis in children with Hodgkin lymphoma who were treated on frontline Children's Oncology Group or COG studies is associated with greater odds of a positive positron emission tomography or a PET scan after 2 cycles of chemotherapy. But skeletal muscle mass and BMI at diagnosis were not associated with this early response. But we also know that body composition changes rapidly after treatment initiation. We have previously demonstrated significant gain in adipose tissue mass and decline in skeletal muscle density through assessment of body composition from CT scans performed a median of just 48 days apart. However, previous analyses have been limited by heterogeneous diagnoses and therapeutic exposures, and whether change in body composition is associated with relapse risk in children with Hodgkin lymphoma has remained unexamined. Thus, we designed this study to examine change in body composition after 2 cycles of chemotherapy among children with Hodgkin lymphoma, and to examine the association between this change in body composition and the hazard of relapse by 5 years among these patients. Eligibility for inclusion in this analysis included having enrolled on a frontline study for children with intermediate and high-risk disease, availability of pre-treatment and post-cycle 2 abdominal CT scans, and having had an early response assessment using a PET scan after 2 cycles of chemotherapy. CT images were obtained from Imaging and Radiation Oncology Core, and clinical and demographic characteristics, as well as disease and vital status at last follow-up, were obtained from COG Statistics and Data Center. Body composition assessment was performed using a commercially available software at the 3rd lumbar vertebral level, or L3. We identified 2 consecutive images per patient at this level, and then used the semi-automated module of the software to tag segments of interest, which included skeletal muscle area, or SMA, as well as visceral, subcutaneous, and intramuscular adipose tissue, which were then added to obtain total adipose tissue, or TAT. This was repeated at both time points, pre-treatment and post-cycle 2, and the difference between the average at these 2 time points was calculated as the change in body composition. Our primary exposure was an extreme gain or loss in skeletal muscle area, or SMA, and total adipose tissue, or TAT, between these 2 time points. Extreme gain was defined as an increase greater than median in either of these 2 segments, and extreme loss was defined as decrease greater than median. Our outcome was relapse-free survival from the end of cycle 2. The association between extreme change in body composition and relapse-free survival was estimated using proportional hazards regression model, treating death as competing risk. We performed this analysis for the overall cohort and then also stratified by PET2 response as well as by sex and age at 12 years, given the association of this age with survival in Hodgkin lymphoma and also as a surrogate for puberty onset. Of the approximately 1,900 patients enrolled on the two-parent trials, we had pre-treatment body composition for a little over 1,300 patients. Of these, 1,033 patients had undergone early response assessment by a PET scan after 2 cycles of treatment. And of these 1,033 with PET2 data, 951 had a digital abdominal CT scan after 2 cycles, and thus constituted the final analytic cohort for this study. Here we highlight characteristics of the entire cohort, as well as by PET2 response. The median age was about 15 years, and a little over half for male and non-Hispanic white race ethnicity was the most common. Almost half presented with stage 2 disease, about 74% presented with bulk disease, and about 31% had B symptoms and presentations. Patients with positive PET2 were more likely to present with bulk disease or B symptoms. And importantly, baseline body composition did not differ by PET2 response. In this slide, we show longitudinal changes in body composition between pre-treatment and post-cycle 2 in the entire cohort. Overall, there was a decline in skeletal muscle area by the end of cycle 2. About 67% of patients experienced a decline in skeletal muscle, and about 32% had an increase. 34% had a decline greater than the median and were categorized as extreme loss in SMA. 16% had an increase in SMA greater than median and were categorized as extreme gain, and about half had stable SMA. Next, we found that overall there was an increase in total adipose tissue. About 36% of patients had a decrease in total adipose tissue and 73% had an increase. Similar to before, 13.6% were categorized as having an extreme loss in total adipose tissue and 36% had extreme gain. Remainder half had stable TAT. The proportion of patients with extreme gain or loss in these body composition segments was similar by PET2 response. We then examined the association between change in body composition and relapse in the entire cohort. Among all patients, neither gain or loss in SMA or TAT was associated with relapse. We then stratified the analysis by PET2 response and found that among patients with negative PET2, extreme changes in SMA were not associated with relapse risk. However, an extreme gain in total adipose tissue was associated with a 1.77-fold greater hazard of relapse in a multivariable model. Extreme loss in adiposity was not associated with relapse. Finally, among those with positive PET2, no association between change in body composition and relapse risk were identified. We then stratified the analyses by age and sex among those with a negative PET2 and found that males and children 12 and older with extreme gain in adipose tissue had an elevated hazard of relapse compared to those with stable adipose tissue. We also explored changes in adipose tissue segments and their association with relapse among patients with a negative PET2. About 1/3 of patients had extreme gain in visceral and subcutaneous adipose tissue, and 1/3 had a decrease in intramuscular adipose tissue. Multivariable models demonstrated that extreme gain in subcutaneous adipose tissue was associated with an increased hazard of relapse. Finally, we examined predictors of extreme gain in adipose tissue among those with a negative PET and found that male sex, higher disease stage at diagnosis, and presence of B symptoms were associated with increased odds of extreme gain in adipose tissue. So to conclude, we highlight that children with Hodgkin lymphoma undergo significant changes in body composition during early phases of treatment. Among patients with a rapid early response assessed by a PET scan after 2 cycles of chemotherapy, extreme gain in adipose tissue is associated with a 1.8-fold greater hazard of relapse, and that skeletal muscle changes in children were not associated with the risk of relapse. Limitations of our study include that children in this analysis had received a cytotoxic chemotherapy backbone. Treatment for childhood Hodgkin lymphoma is increasingly incorporating immunotherapy. Therefore, these associations will need to be retested among children treated in a more contemporary cohort. We also didn't have height or weight at the end of cycle 2 and thus could not examine whether changes in BMI are also associated with relapse. To conclude, we show that body composition assessment using clinically indicated and readily available CT scans highlights significant changes early during treatment of children with Hodgkin lymphoma, and that excess gain of adipose tissue among children with a rapid early response is associated with an increased hazard of relapse. And finally, I would like to acknowledge my mentor, my research team, funding sources, and all the patients and families who had enrolled on these clinical trials. That is it. Thank you.
Thanks, Aman. So we do have 8 minutes left. So if we have any questions of our 4 speakers.
I can ask maybe for
Yeah,
no.
Radhika, come on. Yeah.
I was actually curious on how many people had the combination of TBI and smoking, because I think the confidence intervals were really wide for the high-risk groups, like the last 2 on the graph that you showed. Is this like maybe few patients that are really at high risk because of like maybe other factors?
Actually, so I'm not exactly sure how many we have with the combination of smoking and TBI right now.
Uh-huh.
And for some reason, it's like my PowerPoint slides, they all went white.
Yeah, I think it's maybe 16. I guess like where you showed the hazard ratios for the combinations.
Yeah, it's not opening with me right now. Sorry. Okay. So if I can't get the number right now, I can email it for you for sure.
I was just
Yeah,
curious.
yeah, that's very good.
Are you asking? I have the manuscript open. It's accepted in Blood Advances. So what the question that you're asking is that how many people had a combination of TBI and smoking? Is that correct?
Yeah, I think the last 2 groups which were really showing high risk.
In their association.
Mhm.
Here, let me tell you. So hold on for a minute.
Yeah, it's like 1.4, 15.5. It's small sample size compared to the others, which is
But it's not terribly small. It's
yeah.
still, and hold on, show that slide again.
So for some reason the slides are not showing, so I opened the
So
manuscript.
what it is what that last slide where she's showing the current smoker is while 45% of the people were smokers before BMT, only 4% remained as current smokers because they all stopped smoking after BMT. However, if you even look at ever smoking, there is an association between ever smoking and TBI. The interaction remains. So that number is fairly large. And what we are suggesting is that people who are ever smokers and have received TBI also undergo screening. So if you see, former smokers are at a twofold increased risk.
Okay, so we have around, these are the numbers. So with no TBI, so you are asking about TBI and current smokers, right?
Yeah.
So we have TBI and current smoker, we have 88, and among those 4 developed lung cancer.
But if you look at TBI plus, so what you don't show out here is TBI and ever smoker.
Yeah.
The TBI and ever smoker group is fairly large. Here at the bottom, you see that TBI.
This is among the allogenic alone. So it's probably
446 people.
Yeah.
So it's not such a small number. It is there.
So we had a very small numbers. If we want to look at like TBI dose, it was like the non-myeloablative TBI group. It was like so little numbers. So combining those both, no TBI, it gave us higher numbers. And that was one of our limitations.
So Radhika, it's the current smokers are small. It's only 4%, but the ever smokers are also at increased risk. And that's about 400 people in this cohort of 2,000 and about 800 people in the cohort of 4,000.
Okay.
So it's about 25% of the people.
Thank you.
Yeah. Okay. Any other questions? Yes, Wendy.
Amin, can you tell us where you're taking the study next, or what are your next steps?
Yeah, so that's what we're working on our next grant with this. I think, obviously there's many questions on why body composition is affecting relapse risk, and so we want to explore, whether it's drug pharmacokinetics that are being influenced by these changes in body composition, or in a disease like Hodgkin lymphoma, is it the effect of inflammation that's contributing, and other factors like pharmacogenomics that might be playing a role. And so that's kind of the next step that we want to explore using this cohort, but then also more recently treated patients on our high-risk study, which included immunotherapy drugs like brentuximab.
Thank you.
Antonio.
Yes, Ali Rohan.
We couldn't hear you, Antonio. I'm sorry. Okay. You're muted now. Anybody else? All right. Radhika, what I want you to tell me is, what are the reasons you're finding that it's the younger people with clonal hematopoiesis who are at increased risk of stroke-related mortality? So what is causing clonal hematopoiesis in these younger people? What's going on out there?
Yeah, I guess. I think for mortality associations, maybe my guess is that if you're older and have clonal hematopoiesis, it doesn't really matter because other factors are going to increase the risk of mortality. Maybe they have like other reasons of why they're dying. And one of the cohorts that was included in the original NEJM paper, it included really younger populations, so early onset heart attacks. I think it's a population study from Pakistan, if I remember, and they included people who developed heart attacks in their 40s. So at age where we don't really see those kind of complications. And that study showed that in that particular cohort, there was an increased, almost fourfold increased risk of developing heart attack if they had CHIP. So I think CHIP causes more adverse events if they develop it at younger age.
But what the question is, why?
Yeah, I guess like in these
You
populations.
have the cohort to be able to look at that question.
Yeah, and I think we started off with this risk factors for CHIP analysis, and it always boils down to age and the same demographic factors. So if they're older,
No. If you restrict the cohort to the younger age group and look for risk factors for developing CHIP in that age group.
Yeah, we haven't done that in our study, mainly because our sample sizes are really small to be able to find those associations. But
have you looked at it?
We have looked at, I don't think anything stood out in our CHIP, like risk factors for CHIP analysis.
Did you look at a stratified sample of the younger age group?
Yeah, I'll have to go back and see if there was any signal, but our CHIP numbers in the younger age group are small to start with because there are only few people that develop CHIP at a younger age.
I think it seems to be the group that is really causing us trouble. For example, in our lymphoma study, what we found was that when we looked at Hodgkin lymphoma patients, non-Hodgkin lymphoma happens in the older age group, and the CHIP story is very different there. In the Hodgkin lymphoma people, which was happening at a younger age group, the CHIP, which was developing, was primarily TP53. And that was what was causing all the trouble. So you might want to look at your younger age group and really take a good look and deeper look at that.
Yeah, we'll be able to do that once we sequence all of regards.
No, even in this group, in your risk factor analysis group, which is your K, right?
Yeah,
You
I
should look at that. Yeah.
with the numbers. So when we go to these like really small frequency mutations like TP53 and PPM1D is actually what has been shown to be associated with stroke associated mortality. Our numbers are really small. And I think even in this, we have seen that PPM1D was associated with mortality in this cohort.
Yeah, let's take a look at your risk factor analysis in the younger age group. Okay?
Yeah, we can do that. Yeah. Okay, thanks.
Anything else, anybody? All right. Thank you very much. See you next month. All right. Bye, guys.